Congenital heart disease and ASD. Advances in pediatric cardiology over the past 3 decades have resulted in the survival of a large number of individuals with congenital heart disorders into adulthood. Management of these patients is a challenging area of cardiology, with over 100 separate diagnostic conditions. Congenital cardiac abnormalities can be associated with genetic syndromes or other diseases. Table 30. Abnormalities are divided into cyanotic and acyanotic conditions. The most common conditions are reviewed in this section, Table 31. Diagnosis of these conditions depends on accurate imaging of underlying cardiac abnormalities. This is increasingly performed using non-invasive techniques such as echocardiography and cardiac MRI. Both of these diagnostic methods can also be used to calculate intracardiac shunts, which play an important part in determining treatment. As a consequence, cardiac catheterization is performed less frequently. NB. In congenital heart disease, particular care should be taken to prevent infective endocarditis associated with dental or surgical procedures by using appropriate prophylactic antibiotics. The highest risk is associated with high-pressure jets of blood. Tetralogy of Fallot. Ebstein's anomaly. Ventricular septal defect. Patent ductus arteriosus. Coarctation of the aorta. Acyanotic congenital heart disease. Atrial septal defect. Anatomy, pathophysiology, and pathology. An atrial septal defect, ASD, may be ostium primum, secundum, or sinus venosus in type, Fig 65. The hemodynamic consequences depend on the size of the defect. Enlarger defects, blood can shunt from the left atrium to the right because the right ventricle, RV, is more compliant than the left. As a result, over time the RV may dilate and fail, leading to the development of pulmonary hypertension and possibly Eisenmenger's syndrome. NB. A patent foramen ovale is common in young people. It does not permit left-to-right shunting but allows right-to-left shunting when right atrial pressure exceeds left, e.g. Valsalva maneuver. This can result in an increased risk of stroke as a result of paradoxical embolism. Epidemiology. ASDs are the most common congenital heart abnormality and account for around 30% of all congenital heart defects in adults. Female-to-male ratio 2:1 and 75% are ostium secundum. Clinical presentation. In most adults, ASDs are asymptomatic and discovered incidentally as a result of other investigations. Symptoms are more likely if there is a left-to-right shunt and include atrial arrhythmias, including atrial fibrillation, atrial flutter, and sick sinus syndrome, exertional fatigue or dyspnea, right heart failure, stroke or other arterial territory infarcts, e.g. lower limbs, secondary to paradoxical embolism. Physical signs. Along with increasing flow through the right heart, an ejection systolic pulmonary flow murmur and wide fixed splitting of S2, equalization of right and left ventricular stroke volumes throughout the respiratory cycle, can be heard. RV heave with large shunts. NB. There is no murmur across an ASD itself. Investigations. ECG. Look for the following: right axis deviation and right bundle branch block. Left axis deviation in ostium primum defects. Atrial arrhythmias. Chest radiograph. Look for cardiomegaly, from right atrial and RV enlargement, dilated pulmonary arteries and pulmonary plethora indicating increasing pulmonary blood flow. Echocardiography. Transthoracic and transesophageal echocardiography can be used for confirmation of diagnosis. Transesophageal echocardiography with microbubble contrast study is ideal for visualizing shunts. Fig 66. Treatment. Surgical and percutaneous closure are both possible. Hemodynamically non-significant ASDs do not require closure unless to prevent paradoxical emboli. In asymptomatic patients with a pulmonary to systemic flow ratio, shunt, in excess of 1.5:1 or mild to moderate pulmonary hypertension, closure should be considered. Prognosis. Shunt 1.5:1 has an excellent long-term outcome. Shunt 1.5:1, if untreated, restricts life expectancy to fifth decade, RV failure, rarely Eisenmenger's syndrome. Good long-term outcome if ASD is closed before development of pulmonary hypertension.